Good morning, good afternoon. This is Janet Poole from Thomas Jefferson University Hospital. I represent the Professional Development Department, and we are a provider of continuing nursing education for this program today, joining forces in innovative in-home intervention for veterans with traumatic brain injury and their families for today. The participants who successfully complete this activity will be awarded a maximum 1.0 contact hour, and requirements for successful completion include registration, attending the entire program, and completing the online evaluation in order to receive full contact hour credit. There are no exhibitors or commercial support for this program, and the members of the planning committee do not have financial arrangements, interests, or affiliations related to the subject matter of the presentation. As a registered participant, you will receive an evaluation to complete via email address you entered during the registration process, and you will receive the evaluation between 1 to 3 days post-program. You must complete the evaluation to receive the contact hours, and you have 30 days from the receipt of the first time-sensitive email to complete the evaluation, and you'll also receive a reminder email. So you'll have several emails to remind you to complete it. So click the link embedded in your email, complete the survey, hit submit, and once you do that, you will receive a certificate of attendance for the online program. It will be sent to you electronically, and we'll have the number of contact hours as an attachment. But if you have any questions, please call our office or contact our office at nurse.ce@jefferson.edu. Thank you very much.
Good afternoon, alumni, students, faculty, staff, and friends. I am pleased to welcome you on behalf of the entire Jefferson College of Nursing team to our visiting scholar presentation, Joining Forces with Veterans and Families, a randomized controlled trial of an innovative in-home intervention for veterans with traumatic brain injury and their families. Today's visiting scholar, Dr. Helene Moriarty, is an inspiring nurse scientist with robust contributions to nursing research spanning the last 4 decades. Dr. Moriarty is currently the Diane and Robert Moritz Jr. Endowed Chair in Nursing Research and Professor of Nursing at Villanova University. She is also a nurse researcher and co-director of the Interprofessional Fellowship in Patient Safety Program at Corporal Michael J. Crescent's Veterans Affairs Medical Center. Dr. Moriarty's presentation will provide you with an understanding of the impact of traumatic brain injuries for veterans and their families, and the positive effects of our current project, the Veterans In-Home Program, an intervention that is delivered in the home setting. Today's event supports our commitment to the needs of military veterans and their families. And as a Navy nurse myself, I recognize the unique contributions of veterans and the silent battles many of them face daily. We at Jefferson are entrenched in the belief that veterans are innovative, resilient, team-oriented, and comfortable in stressful situations. That's why veterans make incredible nurses. And Jefferson College of Nursing is committed to providing access to nursing education for actively serving military and veterans and caring for the unique needs of soldiers who have returned home. And I know I am representing that we can fill a need for nursing education for those who are serving or have served. But the truth is that nursing needs individuals who have been trained in this type of service and leadership, and we would be better for it. As the result of our generous Stratton gift, JCN has its own pilot study with the veteran population. The use of service dogs in veterans with PTSD, or post-traumatic stress disorder, and traumatic brain injury. And it's headed up by our wonderful faculty team of Dr. Jennifer Sheeroff and Jackie O'Rourke-Fulford. This study will conclude this month, and we will be eager to share our results, and hopefully we'll find that it has an impact on veterans' daily lives, similar to the work of Dr. Moriarty. And now I am pleased to continue today's program and introduce our Associate Dean of Research and Innovation, Dr. Joanne Robinson.
On behalf of the Jefferson College of Nursing Office of Research and Innovation and the Thomas Jefferson University Alumni Office, it is my great pleasure to welcome you to the final session of our 2020-2021 Visiting Scholar Series in Nursing. Generous support from the Stratton Foundation allowed us to make this series possible, and we thank them. Dean Marino just spoke about the what and the why of today's session and highlighted the enormous accomplishments and contributions of today's visiting scholar, Dr. Helene Moriarty. What I can add are a few personal notes. I first met Helene when she was a full-fledged nursing PhD student at the University of Pennsylvania, and I was still trying to get in. Her enthusiasm, generosity, warmth, and passion for improving lives through nursing research inspired me then and continue to inspire me as I traversed the Penn Nursing PhD program myself, and after that had opportunities to work with her over the past 25 plus years. I recall that Helene's dissertation chair, Dr. Laura Heyman, often boasted that Helene had produced a Cadillac dissertation. And I am here to tell you that Helene has continued to drive high-end nursing research, scholarship, education, and clinical practice throughout her career. We are very fortunate to get this sneak preview of Helene's latest work. Yesterday, she produced Cadillacs. Today, it's Lamborghinis. Thank you for being with us today, Helene, and now please take it away.
For that wonderful introduction. Joanne and I go way back, so I'm thrilled to be with her, with your dean, and with the entire Jefferson community. And I don't even think I could ever drive a Lamborghini, Joanne. It would be way beyond me. But I am just thrilled to be here to share my work and also to gather your inputs, your ideas, because when I talk with others about my work, it moves me forward because I can think about things with fresh perspectives. And so I am going to share my screen. Okay. So I'm talking about joining forces with veterans and families in an RCT that was an innovative in-home intervention. And I bring you greetings from Villanova and from the Corporal Michael J. Crescenz VA Medical Center in Philadelphia. I have to acknowledge the National Institute of Child Health and Human Development for funding, also the support of the VA Medical Center. And of course, I am just so grateful to the veterans with TBI and their family members who shared their stories with us in this study. I also have to make disclaimers. And of course, I have to recognize a just fabulous interprofessional team from VA Medical Center, from Perelman School of Medicine, from Thomas Jefferson University School of Health Professions, and Laura Gitlin, who was at Johns Hopkins at the time that this study was being conducted. So let's talk about joining forces. How many of you have heard of this national initiative? It was kicked off in 2012 by Michelle Obama and Jill Biden. And the goal was to educate over 3.5 million nurses about the unique needs of veterans and their families and how to best support them. So nursing schools throughout the country were all part of this. And another aspect of this was really getting the message to nurses and other health professionals that you always ask the question when you're interacting with a patient, a family member, have you ever served in the military? And if they say yes, then you would ask some additional questions that might reveal some very specific issues or challenges for that veteran. Now, TBI, traumatic brain injury, is a very complex problem. When you think about it, the brain affects how you think, feel, act, it is just an extremely complex organ. And so we have an interprofessional team that I think is very important to look at the problem of TBI from varied perspectives. So you can see in this picture that everyone is looking at the elephant from a different vantage point. And it's so important in an interprofessional team to do the same when you're thinking about a complex problem. Traumatic brain injury is called the signature wound for veterans returning from Iraq and Afghanistan, affecting up to 23% of veterans. The major source of TBI with soldiers are blast waves from IEDs, and this causes the shaking of the brain within the skull and diffuse axonal injury. But TBI is also a major public health problem in civilians. You can look at some of these pictures and identify sources of TBI. In the right corner, that represents the bombings at the Boston Marathon, where we saw many TBIs. Of course, we also have TBIs from sports, car accidents, etc. The sequelae from TBI are very broad and diverse and have a profound impact on functioning, quality of life, and community reintegration. So there are cognitive changes, such as problems with memory, planning, organization, physical changes listed here, psychosocial changes, having a short fuse, depression, anxiety, and family members talk about how the person they love with TBI is a different person. I just wanted to show you this wonderful photo voice product from a veteran. It was in Galatru's VA-funded study, and he used a camera to show you and to talk about the impact of TBI for his life and his functioning. So I just wanted to read it quickly because I think it captures the profound impact of TBI. The big hole to me represents the after effects of an IED. The crater is what we call them over there. I took a blast from an IED. It was the cause of my TBI, the memory loss and the migraines, the headaches and stuff like that. I have this traumatic brain injury thing, but it's hard to explain. I get headaches, I get dizzy, I throw up, weird things I cannot remember that used to be kind of like muscle memory. Sometimes I look at jars. I forget, do I turn it left or right? I have to look at it sideways and think about it. When I'm in the bathroom, I can't figure out if I shampoo first or use soap. And then I cannot remember what I did. I have to make this routine for everything. TBI also has implications for community reintegration. And community reintegration is considered to be the premier goal of rehab. It involves participation in life, in work, school, family, friendships, meaningful activities. But we know from a fair body of research that it's very difficult for veterans when they're returning from deployment to reintegrate into the community. In Stephen Sayer's research, veterans talked about feeling like strangers in their own families, feeling distance from their children, and not feeling that they fit in anymore with their friends. There's a book by Sebastian Junger called Tribe, where he equates being in a military unit with a tribe. And in a military unit, there's a tremendous sense of cohesion, of belonging to the unit, of looking out for one another, of having each other's back. There's also a tremendous sense of mission, leadership, identity. And so you can imagine with the transition after deployment to the community that many veterans struggle with not having that same unit cohesion and not feeling the same sense of purpose in life and identity. We also know from the literature that TBI can create challenges for adult family members: depression, caregiver burden, feeling isolated, changes in quality of life, financial problems. But I wanted to point out that the two most common problems reported by TBI caregivers, family members, are depressive symptoms and caregiver burden. And that's why we decided that those would be two of our outcomes in our intervention research, in addition to community reintegration for the veteran. Family members say that it's the emotional changes that are the most difficult for them. and that they often experience a sense of ambiguous loss, where the person that I love with TBI is not dead, but the person that I knew no longer seems to be with me. And that creates a tremendous sense of ambiguous loss. There has been just recently more attention to the needs of families, but there's a huge gap in knowledge and services. We know that when families are more involved in rehab, that veterans and civilians with TBI do better. But we also know that families need support for themselves. And yet very few intervention studies have included both the person with TBI and the family. And so that is the gap in knowledge and services. In response to that, we developed the Veterans in-Home program called VIP, which was designed to be innovative, building on existing literature, but also being different. So in VIP, we don't focus on fixing the deficits. We focus on changing the environment to be a better fit for the person with TBI. Our intervention occurs in the home. And so we believe that the intervention strategies are better applied to daily life. Our intervention focuses on the veteran and the family as partners in care, and the family is an integral part of the care team, versus in existing literature and services, there's very little family focus or systematic engagement of families. So in our study, we wanted to look at evaluating the acceptability and efficacy of VIP for veterans on community reintegration, physical, cognitive, and psychosocial functioning, and targeted outcomes, which I'll explain in a few moments, and also evaluate acceptability and efficacy for family members in depressive symptoms and caregiver burdens, since they're the most commonly reported problems. And also we wanted to look at the impact on caregiver satisfaction, because we wanted a more positive type of outcome. And there is some literature suggesting that for some family members of those with chronic illness, there's a sense of joy or affirmation or meaning from the experience. The VIP program was delivered by OTs at Jefferson. It involved 6 home visits and 2 phone contacts over 4 months. And it targeted the environment. So the goal was to modify the environment to be a better fit for the person with TBI. And through that, you have more positive affect and more adaptive behavior. But we also used family systems theory to guide our research, in that we wanted to involve families because family involvement could contribute to better patient outcomes. For example, we would ask the family about what is happening with the veteran, and we would use their insights to help us understand the problems. Families would reinforce, so important, would reinforce the intervention strategies between the intervention sessions so that veterans and the family members could practice the strategies. And also family involvement, we believed, could lead to better family outcomes, because families are receiving education about TBI, they're receiving support through symptom management and developing new coping skills. And so the intervention could benefit both veterans and families. And here is a map that demonstrates our 2 theoretical frameworks. You can see that this intervention is in the home, including the family member. It's based on the person environment fit framework and family systems. And for our proximal outcomes in this particular study in VIP, we looked at the first 2 outcomes. And then for family members, we looked at burden and depressive symptoms and also caregiver satisfaction. And I'll be talking about how we're building on this research in the distal outcomes at the end of the presentation. So VIP was designed to be in the home. We think the home is the optimal place for the intervention because it's the context for everyday functioning. So intervention strategies can be transferred to daily functioning. We could interact with the vet and family in their own environment, observe their functioning, observe relational issues, and modify the home environment to be a better fit. And so our intervention was designed to teach veteran and family member how to better manage TBI symptoms, to remain independent, to make the home safer, and also to try to use stress reduction techniques. These are the 6 intervention components that aim to help veteran and family members manage TBI symptoms. So we modify the environment. We try to simplify and modify different tasks and activities. For example, using schedules, alarms, control centers, learning new ways of doing things, compensating for memory issues, activity enhancement, working with the veteran to increase their engagement in meaningful activity, and how to break down the steps required to initiate and maintain activities. Stress reduction, another component, emotion regulation, having a short fuse, having difficulty managing emotions is a problem with TBI. And so part of the intervention was identifying and reducing the triggers that could lead to problems. And then also we provided TBI knowledge. This is a description of the VIP intervention, and I'm not able to go through all of this, just to say that we had very defined goals and activities for each of the sessions. And then we had a control condition, which was standard TBI care that was offered at the VA polytrauma program in the outpatient clinic. And we augmented that with 2 phone calls. So here's our design. It was a randomized controlled trial, VIP plus usual care versus control, usual care plus 2 calls. Our sample consisted of 81 vets with TBI and 81 family members. So each veteran identified a family member who was actively involved in his or her life and who either lived with him or within 30 minutes travel time. The veteran and family member were interviewed in their home at baseline. Then we had random assignment. And then we had to be sure that the interviews were conducted separately outside the hearing of each member. We had a follow-up interview 4 months later. Interviewers were blinded. And then we also ended with a qualitative interview with a subsample of VIP participants, because we wanted to understand what was the experience for them of the intervention, what was helpful, what was not helpful. Our inclusion/exclusion criteria are listed here. Here's our consort chart. We can see that we started with 110 screens, and we ended up with 81 randomized, 41 in the intervention group, and 40 in the control group. We were very careful to try to maintain treatment fidelity. In other words, that we were following the treatment protocol, that we didn't have drift from that. And so we had regular debriefing meetings of the team, and we observed 8% of the intervention sessions to be sure that the interventionists were following the protocol. We had a number of instruments that were administered to veterans at baseline and follow-up, and also to family members at baseline and follow-up. And so for the veterans, I talked about that one of our outcomes was community reintegration. We also had an outcome on everyday functioning that was measured with the patient competency rating scale. And the targeted outcomes were patient-centered targeted outcomes, which I'll explain. For family members, we used the CESD for depressive symptoms, caregiver appraisal scale for burden, and the same scale for caregiver satisfaction. When we were thinking about our outcomes, we thought about standardized outcomes based on previous literature, but then it occurred to us that we could be missing something that is so important. Because there is such variability in TBI symptoms, we could be missing the outcomes that are most important and meaningful to patients and families themselves. And so we developed what we call targeted outcome questions, where we asked at baseline what you consider as the most important. And then number 1 was number 2, 3 problem your TBI is causing you in the last month. And then how hard is it to deal with this problem on a scale from 0 to 4? And then we asked the same question at follow-up around the same problem. And so we were able to identify in a qualitative way, what are the problems that are most important to veterans and families? But then in a quantitative way, we were able to measure whether there was a change in being able to manage the problems over time. And so we published that article, and I was very, very proud of this very patient and family-centered measure. Let's talk about our sample. As any good researchers do, you've all learned this in your classes for students who are on the program, you check for equivalence of groups at baseline. And so we looked at our 2 groups, veterans and VIP, veterans in the control group, no significant differences between them. We also looked at family members at baseline, VIP group, control group. We did not find any significant differences except for financial difficulty and Hispanic ethnicity. And so we entered those as covariates to control for those. And I'll just go through the characteristics of the veterans very quickly because I know time is of essence here, but the mean age was 40. And you can see that we had heterogeneity in race. You can see that most of the TBIs, about 2/3 were mild. It was a median time of 6 years since the most recent TBI. And look at this, 37% of our veterans had experienced more than 4 TBIs. That's pretty amazing. Our veterans came primarily from Iraq and Afghanistan war cohorts. And in terms of our family members, a very similar age, again, some heterogeneity in race, and most were spouses, partners to the veteran. So I just wanted to give you a sense of some of the problems that the veterans reported in the VIP intervention, and then intervention strategies to address that. So they talked about losing keys and other items leading to frustration and blow ups. And we know that we all lose keys, myself included, but for a veteran, a person with TBI, losing keys can lead to an emotional blow up that then creates great family upset. And so the OTs worked to create a control center near the front door that had everything that the veteran would need for different situations. Missing appointments and deadlines was another problem. We had training with iPhones, use of alarms, notes, apps to communicate with the spouse. Difficulty socializing. The OTs worked with the veterans to start with smaller groups to prepare for social activities, etc. We had some veterans who had tremendous road rage. We had one veteran who would drive around on a motorcycle and just would be cursing and yelling and have great road rage to others, which was dangerous to her and to others. And so we had interventions around preparing for driving. So you can get a sense of how these strategies were designed to modify environments to be a better fit so that the person with TBI could better manage their symptoms, and the family members could also do the same. So our data analysis was analysis of covariance, controlling for some baseline values and other covariates. So you're really probably wondering, well, what are the results? What are the results? Here you can see in terms of VIP treatment effects, you can see that there were significant differences between the two groups in community reintegration and targeted outcomes. No significant difference in functioning between the two groups and in the different types of functioning. For family members, there was a significant difference in depressive symptoms and caregiver burden between the two groups, and no significant difference in caregiver satisfaction. We also had to look at not just the outcomes, but is this intervention acceptable for veterans? If it's not acceptable, no matter what your outcomes, you're in trouble. So we looked at participation, and we had a high percentage of the veterans who were randomized who did participate. They participated in a high number of sessions. We had a tool to measure acceptability, and 88% said they would be willing to participate in another study on TBI, another measure of acceptability. So just to summarize our veteran and family outcomes, veterans and VIP showed increased community reintegration and increased ability to manage targeted outcomes overall compared to controls, and family members in VIP showed lower depressive symptoms and less caregiver burden. Everyday functioning did not differ between the two groups. And we think that's because the functioning tool measured primarily activities of daily living, and it didn't capture some of the nuances of functioning. And caregiver satisfaction did not differ. One explanation for that, perhaps, is that caregiver satisfaction of family members in both groups was very high to begin with, a 4 out of a highest score of 5. And so there wasn't a lot of room for improvement there. And acceptability of the intervention for both groups was high. But we also wanted to look at, in our qualitative data, we wanted to understand how did the intervention work? And it's always so important to think about that in intervention research. I believe that the quantitative data, they're quite informative, but the qualitative data puts the flesh on the bones of the quantitative data. And so our interviewer said to the veteran, can you tell me a little bit about how it went having your wife present at the later VIP meetings? And the veteran said there were things that came up during the meeting that were very surprising for my wife. I've known this woman for 20 to 22 years. She should be able to judge how I'm feeling, my moods, but that's not always the case. My wife viewed me as this hardcore professional soldier. It still hadn't registered that I had limitations and I had needs that I'd never had before. My wife's a very compassionate woman and she wants very much to help me. You know, it's hard to help somebody if they don't tell you what they need. So there were things that came out during the meeting that definitely helped both of us. This was such an eye-opener to us that this veteran is saying it opened up the family system. It opened up communication between he and his wife, that he was able to share with his wife what was going on with him from TBI, and then she could better support him. Also, a family member here talked about feeling that learning through the intervention that the behaviors associated with TBI are normal, and that it wasn't just that the veteran wasn't trying hard enough, and it's just that I had to learn how to work with him. So again, a powerful testimony to how the intervention worked. And the veteran said the most helpful was the hands-on stuff that she gave me to do, and stuff like a book that we wrote stuff down into. So that's the goal setting piece. And the family member says he has these appointments to go to therapy. You're like, I don't want to go. When they were coming here, he was up, he was ready. Having the opportunity where resources came to our house was invaluable. So this gets to the access issues, and access issues have plagued the VA, especially over the last 5 years. And so this intervention appeared to increase access for the veteran with TBI and the family member. So let's talk about what are the implications of these findings. And you probably have some other ideas about this that I would love to hear. But this is, VIP was the first intervention showing benefits for veterans with TBI and family members, the first and only. It addresses gaps in services in the VA polytrauma program, because in the outpatient VA program, families are not systematically engaged in rehab. Our findings support efficacy and acceptability of the intervention. We think this is a very promising approach to support families, and that it may increase access to care for veterans and families. And it's important to note that in the VA polytrauma program in Philadelphia, that over a period of several years, this is before the study, 75% of veterans in the polytrauma clinic did not complete their treatment plan. And 90-some% completed the VIP program. This intervention also aligns with VA priorities. There's been a tremendous emphasis recently on our need to serve not just the veteran, but also serve their caregivers. And that caregivers are, they're the hidden heroes because they're so important to support the veteran and be engaged in rehab. But also family members can be the hidden victims that are often not recognized by society for what they're going through. We also believe that this study has policy implications, that it suggests that there needs to be reconsideration of the extent of services for family caregivers, family members, and for veterans with TBI. So we could talk about that. But, as in any study, we have limitations, relatively small sample, external validity limited to those in the VA clinic setting. We didn't have an attention control group. And so the implications for future research, we want to replicate it with vets who use and don't use the VA system. We want to replicate with civilians, have an attention control group, have a longer follow-up period, because the follow-up period in this study was 4 months, but we don't know if the intervention effects continue after 4 months. And so, given that what I said about the limitations and the implications, we have designed another study that was recently funded for an R01 by the National Institute of Nursing Research. And it includes an RCT of veterans and civilians with TBI and their families. And we extended the project to address the limitations that I talked about. Sorry, sometimes I have a hard time with this pointer. Okay, so I showed you our theoretical framework before, and what we're doing in the R01 is that we added quality of life as a measure. We added whether or not family needs are met for the proximal outcomes at month 4. But then we also added distal outcomes. So we're looking at our outcomes and whether or not there's maintenance of treatment gains in our outcomes at 10 months after baseline for both the veteran and the family member. And we're also looking at generalization of skills. So are the veterans able to apply the intervention strategies learned in the intervention to new or similar situations or problems? And so if you look at our distal outcomes, this is how we're building on our previous work in the R01. So I wanted to end with some words from veterans and military families. And when you listen to the voices of military families, you will hear their message loud and clear. And this was the impetus for our work, that in a military family, we all serve. These are the references for the 2 outcome papers. We also have 13 other papers from the VIP work. And I thank you for inviting me to share this research, and I welcome your input.
Now we'd like to invite our attendees to share any questions that they have with Helene using the Q&A button located at the bottom of your screen. And we did receive a few during the presentation that we will start with. So Helene, did any of the veterans that you worked with have a pet? And did they talk about the benefits and or burdens of having the pet?
Oh, that's a great question. So we actually had a veteran whose pet died and during the study, and it was very difficult for the veteran. And so we had to provide additional support and refer the veteran for some support services because the pet was like a family member. Yes. And we don't have data on the number of veterans who had service dogs, but that's a great question. We could ask about that in future research. So thank you for that idea.
Wonderful. My next question, can you describe the control intervention and how it was different from the VIP?
So the control was just standard care offered by the VA Polytrauma Clinic. And that standard care varied. I mean, some of the veterans were very involved in receiving care from the polytrauma program. For example, meeting with an OT or PT or neuropsychologist or rehab doc. Some of them were not as involved, but with random assignment, you hopefully you control for that. Because remember, in our study design, the VIP group and the control group all were still receiving usual care. But for the control group, we added 2 phone calls to stay connected, but also for a little bit of attention. But it was not a true attention control group. And a true attention control group has a comparable amount of attention and time in the control group compared to the intervention group. And so in our R01 study, the control group consists of educational sessions, in-person, online, and mailings. And the amount of contact in the control group is similar to in the intervention group. Because people, sometimes in intervention studies, you have to raise the question, well, are the changes I'm seeing just due to the fact that the intervention group is getting more time with the nurse or the OT and more attention? And so you have to control for that.
And speaking of time, we have a question asking, how did you determine the 10-month time frame to look at your distal outcomes?
Oh, that's another great question. So I'll go back one step. The 4-month outcome was based on previous research using the person, environment, fit framework with other populations. So that was a time that was found to be optimal for seeing intervention effects. We chose 10 months because we felt that it's an additional 6 months. It gives the veteran and the family member time to continue to hopefully use and practice the intervention strategies. And also we felt like that was a meaningful time period. So was this an intervention that was still working, at 10 months? Great question. And I think I had a question from Pat Owens. And I do have to respond to Pat. So I have to give a little bit of a story with Pat Owens. Hello, Pat. Just because it demonstrates how did this intervention idea come to fruition. And I will tell you, sometimes in life, you do not anticipate things, you do not plan things, but if you're open to possibilities, lots can happen. So my colleague, Lorraine Winter, was working with a group at Jefferson in the Jefferson Center for Aging and Health. And they had an intervention for family members of persons with dementia and Alzheimer's disease. And so Lorraine Winter came to the VA in Philadelphia and connected with Pat Owens, a wonderful geriatric nurse practitioner in the geriatric clinic, fabulous. And so Pat said, oh, I'd like to be able to be part of this study and enroll family members of veterans with Alzheimer's and dementia in the Jefferson study. So I worked closely with Pat. We went through all the paperwork. In the VA, getting IRB approval can be quite onerous. It takes time. The bottom line is, by the time we got IRB approval, Lorraine from Jefferson said, I'm sorry to say, but we already met our recruitment goals. We don't need to enroll. And we said, oh, this is disappointing. But then I said to Lorraine, but Lorraine, we have veterans with TBI who have some similar, not all similar, but there's some overlap between the symptoms of TBI and dementia and Alzheimer's disease. And we know that family members of veterans with TBI also feel the impact. And so I said to Lorraine, is there any way we could think about modifying the intervention to fit with veterans with TBI and family members? And that's how VIP was born. So you never know. Be open to possibilities in research. You never know where it leads you.
Absolutely. A few more questions have come in, Helene. In your group, how many of the veterans were women, and what role did the team of nurses play in the study?
Great question. So we had a small number of females. I can't remember the exact number, but it reflected the proportion of females in the VA system. Now, that number is increasing, but at the time of our study, I think 8 to 10% of veterans were females, and that was the same as in our study. So we really could not do meaningful analyses to look at differences. It was just too small a group of females. But in terms of the nursing group, I have to say that if I had had more funding, I would have liked to have included an OT and a Psych NP as the interventionist, but we didn't have the funding for that. And so what I felt was that I, as a PI with Lorraine Winter, I brought in the nursing perspective, which is the biopsychosocial spiritual perspective, that I contributed that to the team. Now, we did also have a psychiatric nurse practitioner who provided education to our team about post-traumatic stress disorder, because many of the veterans with TBI have PTSD, they've gone through trauma. And so our entire team, especially the interventionists and the interviewers, really had to gain more knowledge about the nuances of PTSD and how it can show itself and how to work with people with PTSD. And so we had a Psych NP who did that. So I have to admit, sometimes I struggle with the fact that the intervention was not provided by nurses, it was provided by OTs. But then I feel as though because we were building on another model, and because OTs, at least at the time we were developing this intervention, they had more experience with the cognitive changes in TBI and modification of the environment to be a better fit. But I'm okay with it because I view this as TBI is a complicated issue with many, many different symptoms in many areas. And I have a team of all different disciplines addressing it. So I have myself, a research psychologist, a neuropsychologist, a social worker, case manager, a psych NP, OTs, and a statistician. I hope that answers the question, but it's a great question.
Absolutely. And to piggyback off of that, and when we're thinking about environmental factors, we had a question on whether or not you have any thoughts about the application of VIP to a veteran's work environment.
Oh, see, this is why I love to do presentations to wonderful nurses at places like Jeff and other places, because you stretch my mind and you give me some ideas. We hadn't thought about that, but actually that could make sense because sometimes veterans struggle in places of employment and they may be afraid to articulate some of the struggles. And so an intervention that helps them deal with the challenges and perhaps modify the employment environment to be a better fit could be helpful. So you have given me a great idea for the future, whoever that was. I appreciate it.
Oh, that's great. Wonderful. We still have a few more questions. And again, if anyone in the audience has additional questions, please share them with us now. The first is, which tool did you use for acceptability?
We have our own tool for acceptability, and it has been used in other research. It was used, for example, by Laura Gitlin in many of her studies. She was at Jefferson for many years. It was also used by her team. If somebody, I can share that tool if someone's interested. We don't have a name for it, just acceptability tool.
Thank you. We have a note from actually one of our attendees is the wife of a veteran. It says Special Forces Green Beret with TBI, and we want to thank her and her family for their service. She asks, how do you plan on accessing families of veterans outside of the VA in future studies?
So in our RO1, we have 4 recruitment sites. One is VA for veterans, followed by polytrauma. But we have 3 other recruitment sites. We have Remed, Moss, and Penn, Good Shepherds. But we're also expanding our recruitment. So for example, we were asked to present on VIP at a support group for patients at University of Penn who are being followed for TBI. And so we presented our VIP, and then we had some in the audience who said, I'm interested in participating in the next study, which we call HOME. And so we're going to have veterans followed by the VA, but we're going to also have, hopefully, veterans who are followed by other groups, other organizations, not by the VA. And that's really important. I'm glad you brought that up, because with the Mission Act, some of you have probably heard about the Mission Act, there's going to be more VA funding for services to be provided outside VA hospitals. And therefore, we're going to see more veterans in non-VA settings who could be eligible for this study. And I also wanted to mention with the Joining Forces campaign that I mentioned before, that it's even more critical now that nurses and health professionals ask every patient, have you ever served? Because of the Mission Act, you're going to be working with more veterans who are receiving care in the community and not in the VA system. And I have to say that I do believe that most veterans, most health providers, I have to say this, are not equipped, are just not as knowledgeable about the very unique needs and the nuances of different issues for veterans. For example, now we're seeing burn pit exposure. When there were huge fires burning materials and all different kinds of substances, the fumes, the exhaust from that was, being breathed in by soldiers. And now we're seeing, many respiratory issues from that. And I think, Marie Marino, your dean, she is on an expert panel in the American Academy of Nursing, and she and others have, as well as Joanne is on different expert panels, but there's an increasing recognition of our need to study this burn pit exposure and the symptoms it causes. So that's something new. Another example is that we know that veterans who were exposed to Agent Orange in Vietnam have a greater risk of Parkinson's disease. And so those veterans are eligible for services, great services from the VA. But a lot of veterans don't know that. They may not know that. And so sometimes I'm trying to encourage people to, okay, that could be a service-connected disability. You need to look into it, go to the VA, blah, blah, blah. I don't know if Joanne or Marie want to add to that, but really good question. Thank you.
Excellent. And I think we have one more question, which I think will summarize a lot of your learnings. And the question is if there's any advice or thoughts you have on how individuals can support veterans with TBI and their families.
Oh, another great question. Be there. Sometimes it's very simple. Be there, listen. Do not assume because somebody has this, stoic face and smiles that everything is okay. Because I was involved in a study, fabulous study with Galatru, was the PI, where we used photo voice. And so veterans with TBI and their family members, I showed you that one photo voice from one veteran, but we also asked family members to use a camera to express what was going on with them. And these pictures are just, so powerful and so compelling. And the family members talk about walking on eggshells, that I don't always know, what's going to be a bad day, what's going to be a trigger for struggles for my veteran with TBI. And so we actually have an article that came out in the Journal of Head Trauma and Rehab that is called The Emotion Work, the Invisible Emotion Work of Veteran Family, and we don't say caregivers, we say care partners in this study, because society and friends and family and neighbors, they don't appreciate this large amount of emotion work that family members have reported to us. And so we believe that in terms of policy and programs, there needs to be more recognition of this emotion work for family members of veterans and supports for them. Because, there's an old idea, sort of antiquated idea, that only family members of veterans who need extreme help with activities of daily living, that only those family members really need support. And that's just antiquated because there's so much more to the family member's role in supporting the veteran with TBI. And that needs to be recognized and supported and services for that. So for example, the VA has a comprehensive caregiver program, but it has such strict criteria that the veteran has to need assistance with all these ADLs, and it doesn't address the other ways in which family members help. And so, we hope that our research, as well as others' research, will be used to increase the services for family members. And so that's when you think about where you hope your research goes in terms of policy implications, that's a good example. But these, I think, going back to your question, being aware that the smiley face, may not be smiling inside. And ask the person, how are you doing? So many times, and I think this is the problem with nursing and health care in general, when you think about any illness affects the person and the family, but how many times do we not ask the family member, how are you doing? How are you doing with this? How are you integrating this care in your daily life? I don't think it happens often, but I think we need to ask family members of veterans those kinds of open-ended questions, and we're going to be surprised because we're giving people permission that they don't have to be stoic and strong. We don't have to say, oh, you're so strong, so keep being strong. We're giving them permission. We're being open to hearing what's really going on. I think that's the psych nurse in me too.
For sure. But a great thing to keep in mind. We just received one question somewhat related, just wondering if you collected data about care partner burden burden and as a covariant of the family structure situation, whether it be multi-generational families or things like that. Was that a data point that was collected in your studies?
Yeah, so caregiver burden was one of our outcomes, and the family members who received VIP had lower depressive symptoms and lower caregiver burden. But we also did some analyses around the burden variable. And I also want to mention to you that sometimes people think when you do an intervention study, you can't publish, you can't analyze anything until you have your outcomes. Well, that's at the end of the study when you recruited the number you need. But you can do a lot with your baseline data. And so many of our papers came from our baseline data, before anybody had the control group or the intervention. And we looked at relationships. Among all of those different variables, we collected a lot of data. And so, for example, I wanted to look at predictors of family member depressive symptoms. And this gets to the burden question, but I found that family members who had increased caregiver burden, more financial distress, and the presence of a veteran with PTSD, that they had higher depressive symptoms, which has implications for practice. We also looked at, we have a neat tool called Quality of the Relationship. It had never been used in TBI groups before. It had been used in gerontology. It's called Quality of the Relationship. And we asked the veteran about their perception of the quality of the relationship with the family member and vice versa for the family member. And the nice thing about this tool is it also measures giving and receiving. So how much do people feel they're giving and receiving? And we found, which this was a novel, really novel result, was that those family members who reported more receiving, more thanks, more acknowledgement, more receiving from the veteran had lower caregiver burden. And that was an interesting finding because, many times people think with caregiver burden, if you reduce what they have to do, if you reduce the instrumental task of caregiving, it reduces burden. But we found that, when family members felt they were getting something back, they were receiving from the veteran, that they had less burden. And so that has a lot of implications for practice too, and clinical assessment and clinical suggestions to people with TBI. Does that make sense?
It does to me, hopefully to our attendees as well.
I don't know. Did I answer your question? That was a great question. Sometimes I get so excited. I go off on tangents.
Yes, I think so. And I mean, then thank you once again, Helene. This was a wonderful conversation and informative presentation. And I'm judging by the number of questions we received, everyone was really engaged in the topic. We want to also thank everyone for joining us. I know we ran a few minutes over, but we really appreciate your time. We want to invite you to join us for some of our future programs, including next month. We will have a webinar with Jefferson College of Rehabilitation Sciences faculty member, Marie Christine Potvin, who will talk about coaching and context. And this talk uses coaching techniques for those with clinical facing jobs to help coach your patients towards achieving their goals. And then we're returning to the ballpark this summer, and our annual Alumni Day at the Phillies will return on Saturday, August 14th. Registration for that event will open on July 1st. You can find a full calendar of upcoming events at jefferson.edu/alumni events. We also invite you to join the Jefferson Alumni Network and get connected with Jefferson alumni around the world at alumninetwork.jefferson.edu. And if you're interested in learning more about the College of Nursing's postgraduate certificate program in advanced headache diagnosis and management, you can do that at jefferson.edu/JCN headache. Thank you all once again. Have a wonderful day and take care.
Thank you very much.